Hello everyone, this is Dr. Prashanth and welcome back to Public Health Series. In this video, I'll be briefly explaining the National Nutritional Policy. To start with the introduction, undernutrition is a condition resulting from inadequate intake of food or more essential nutrients, resulting in deterioration of physical growth and health. This condition of undernutrition reduces work capacity and productivity amongst adults and enhances mortality and morbidity amongst children. Such reduced productivity translates into reduced earning capacity, leading to further poverty, and the vicious cycle goes on. So let's look at the cycle. Starting from the poverty, which leads to low intake of food and nutrients, leading to undernutrition, leading to stunted development of children and growth faltering, followed by small body size of adults, which leads to impaired productivity, that leads to low earning capacity, and finally again leading to poverty. So, the nutritional status of a population is very critical to the development and well-being of a nation. Now, let's look at the need for the nutritional policy. The problem of undernutrition should be seen as a part of larger set of processes that produces and consumes agricultural commodities on farms, transforms them into food in the marketing sector, and sells the food to customers to satisfy nutritional, aesthetic, and social needs. So basically we need to look at three broad categories or three broad sectors: agriculture, food and nutrition. And the last subset, that is nutrition, is the net result of the other two subsets, that is agriculture and food. Now let's understand this with the help of a diagram. I have highlighted with red circles for agriculture and food industry and green for the nutrition. And I already said that nutrition is the net result of agriculture and food industry. So there are different factors for each industry. For example, resource factor and technology related factors for agriculture, market prices and changing taste of the community for food industry. And there is also linkage between these two factors. For example, resource and market prices. If we are having abundant resources, the market prices will be comparatively less and vice versa. So we need to take into account all these factors while doing any interventions in the policy. Now let's understand this complex nature with some more examples. To start with post-independence India, in 60s we are a deficit country. We used to depend on import of food grains. But in 80s we have a surplus production of food grains. But still the problem of malnutrition is present in India. So this indicates increased food production does not itself will lead to nutrition for all. Similarly, economic development or even the adequacy of food at household levels will not guarantee a stable and satisfactory nutritional status. So, nutrition must be tackled independently along with other development issues. And also the time dimension is very important, and any policy having a mere long-term effect, even if beneficial for the nutritionally at-risk population, would not suffice. So therefore, we need to have both short-term and long-term strategies. So now coming to the implementation strategies, as I already said, we have both short and long-term strategies. So under direct intervention, intervention for especially vulnerable groups, fortification of essential foods, and produce and popularize low-cost nutritious foods, and the control of micronutrient deficiencies amongst vulnerable groups. Under indirect policy instruments, food security and promoting the production and increasing the per capita availability of nutritionally rich foods, policies for effecting income transfers to improve the entitlement package of the rural and urban poor, land reform so that the vulnerability of the landless could be reduced, intervention through health and family welfare and the basic health and nutrition knowledge, prevention of food adulteration, nutrition surveillance and monitoring of nutritional programs by different authorities and boards, research into various aspects of nutrition both on the consumption side as well as on the supply side. And the wages of women shall be at par with that of men to improve women's economic status. Communication through established media is one of the most important strategies for the effective implementation of the nutrition policy. Community participation, it is very important. The active involvement of the community is essential for deriving the maximum benefit from such services by giving timely feedback necessary at all levels. It has been shown that education and literacy, particularly that of women, is a key determinant for better nutritional status. And lastly, the most effective way to implement nutrition is to focus on improving the status of women, particularly the economic status. So now I'll just go through some of the important nutritional programs in India, starting with the Integrated Child Development Services. It was launched in 1975 to reduce the prevalence of malnutrition in the country. And the package of services included are supplementary nutrition, immunization, health checkup, referral services, non-formal preschool education, nutrition and health education. Beneficiaries are children below 6 years, pregnant and lactating mothers, women in the age group of 15 to 44 years. Special Nutrition Program, it was launched in the year 1970-71. It provides supplementary feeding to both preschool children and the expectant and nursing mothers. Balwadi Nutrition Program, it was implemented since 1970-71. It consists of 300 calories and 10 grams of protein per child per day for 270 days a year. Wheat-based supplementary nutrition program was introduced in 1986, where children and expectant and nursing mothers are covered under this program. Tamil Nadu Integrated Nutrition Program was implemented since 1981. Under this project, nutritional surveillance and supplementary nutrition is being provided to children below 6 years and expectant and nursing mothers. And coming to the midday meal program, it was launched in 1956 in Madras, and the objectives are to improve nutritional status of the school children and to attract children to enroll themselves into schools and to encourage regular attendance by providing supplementary nutrition. And under this midday meal program, there are two important initiatives. One is Tithi Bhojan, which is to encourage local community participation in the program, and it seeks to involve the members of the community in the effort to provide nutritious and healthy food to the children. And other is the Akshay Patra. It is the largest partner of the Union Government of India to implement the midday meal scheme in the government run schools of India. And this scheme is based on public-private partnership. And after making many structural changes, in 2021, the midday meal scheme was renamed as Pradhan Mantri Poshan Shakti Nirman or PM Poshan scheme. It is a centrally sponsored scheme, and under this scheme, one hot cooked meal will be provided to the children studying in government and government aided schools. And this is the nutrition norm per child, and this is the food norms per child per day. So for primary school children, 450 calories with 12 grams of protein, and for upper primary school children, 700 calories with 20 grams of protein. And similarly for food grains for primary and for upper primary is given. And now coming to Poshan Abhiyan, which is also known as National Nutrition Mission. It was launched in 2018. It is the flagship program of Government of India. It is to improve nutritional status of adolescent girls, pregnant women, lactating mothers, and children from 0 to 6 years of age. And the key objectives are prevent and reduce stunting in children, that is 0 to 6 years, prevent and reduce undernutrition in children, reduce the prevalence of anemia among women and adolescent girls in the age group of 15 to 49, and finally reduce low birth weight. And now coming to the components of Poshan Abhiyan, first is the convergence, where we ensure convergence of all nutrition related schemes on the target population. And second is the software based tracking of nutritional status will be done using ICDS CAS. And third is the behavioral change, where this Abhiyan will be run as a Jan Andolan, where mass involvement of people is desired. And the community based event will happen once a month to create awareness and address issues. Next is the incentives, where frontline workers will be given incentives for performance. Next is the training and capacity building, where incremental learning approach will be adopted to teach 21 thematic modules. And the last one is the grievance redressal, where a call center will be set up for ease of access to solutions to any issues. And now coming to the next program, Nutritional Anemia Prophylaxis Program, which was started in 1970 to prevent nutritional anemia in mothers and children. And under this program, the expectant and nursing mothers as well as women acceptors of family planning are given one tablet of iron and folic acid containing 60 mg elemental iron, and children in the age group of 1 to 5 years are given one tablet of iron containing 20 milligrams of elemental iron daily for a period of 100 days. And this program covered children and pregnant women with hemoglobin levels less than 8 gram percent and 10 gram percent respectively. And coming to the next program, prophylaxis program against blindness due to vitamin A deficiency. So it was initiated by the government in 1970, and under this program, children in age group of 1 to 5 years are given an oral dose of zero point 0.2 million international units of vitamin A in oil for every 6 months. And during 1980, the Department of Food introduced a scheme of fortification of milk with vitamin A to prevent nutritional blindness. And you can go through the exact dosage I have given below. Next is the goiter control program. It was initiated by the government of India in 1962 to identify goiter endemic regions and to assess the impact of goiter control measures. The key objectives are survey to assess the magnitude of the iodine deficiency disorders, supply of iodized salt in place of common salt, resurvey after every 5 years to assess the extent of iodine deficiency disorders and the impact of iodized salt, laboratory monitoring of iodized salt and urinary iodine excretion. And the last is the health education and publicity. Now coming to the next program, National Diarrheal Disease Control Program, which was launched in 1981. It is to reduce the mortality in children below 5 years due to diarrheal diseases through introduction of oral rehydration therapy. So under this program, the Anganwadi centers of the ICDS scheme have served as a nucleus for the propagation of oral rehydration therapy, which has been found to be an effective measure of preventing dehydration caused by diarrhea. And now coming to the next program, Kishori Shakti Yojana, which was launched in 2006-2007, it seeks to empower adolescent girls to enable them to take charge of their own lives. So the key objectives are to provide the required literacy and numeric skills through the non-formal stream of education, to stimulate a desire for more social exposure and knowledge, and to help them improve their decision-making capabilities, to improve the nutritional, health and development status of adolescent girls, promote awareness on health, hygiene, nutrition and family care, to link them to opportunities for learning life skills, to train and equip the adolescent girls to improve or upgrade home-based and vocational skills. And last one is to help them gain a better understanding of their social environment and take initiatives to become productive members of the society. This scheme is comprised of two sub-schemes. One is girl to girl approach and second is the Balika Mandal to reach adolescent girls. In the girl to girl approach, in each selected Anganwadi, two girls in the age group of 11 to 15 are selected and they are provided with a meal on the same scale as the pregnant woman. And these two girls so identified are to receive in-service training at the Anganwadi from the worker and supervisor over a period of 6 months to become fully equipped individuals capable of managing the center on their own. Coming to Balika Mandal, this scheme had more focus on the social and mental development of girls at age group of 15 to 18. Special focus was laid to motivate and involve the uneducated groups belonging to this age group in non-formal education and improvement and upgradation of home-based skills. And now coming to Applied Nutrition Program, it is an educational program at village and family level that aims to bring about changes. It aims to improve diet by education through self-help, improved production and consumption. These are some of the specific objectives of Applied Nutrition Program: to educate mothers, children and other members of the village community, to encourage the local production of food like pulses and leafy vegetables, to encourage proper methods of storage and preservation of foods, increase the knowledge of methods of hygienic food preparation, and finally to utilize part of foods produced under the program for feeding for the children, especially the vulnerable group of the population. The weekly iron and folic acid supplementation program was started to meet the challenge of high prevalence and incidence of anemia among adolescent girls and boys. The objective of this is to reduce the prevalence and severity of anemia in adolescent population, that is 10 to 19 years. And the target group for this program are school-going adolescent girls and boys in 6th to 12th class enrolled in government or government-aided or municipal schools, and also out-of-school adolescent girls. And now coming to the intervention under this program, administration of supervised weekly iron folic acid supplements of 100 milligrams elemental iron and 500 microgram folic acid using a fixed day approach. Screening of target groups for moderate or severe anemia and referring these cases to an appropriate health facility. Biannual deworming using albendazole 400 milligrams 6 months apart for control of helminthic infestation. Informing and counseling for improving dietary intake and for taking actions for prevention of intestinal worm infestation. Thank you.